Okay, hi, I'm going to start on ankle fractures. Woo! So as usual, I was overambitious, and I initially wanted to do lower extremity ortho, and then I realized I couldn't cover that, and then I did ankle and foot, realized I couldn't cover that. So I'm just going to talk about ankle, and then next touch a Kupa, I'll do foot. Okay, so very quick anatomy. Just focus on the ankle right now, but above the calcaneus is the talus, and then if you look at the cuneiforms, they start first, second, third, starting medially, and you can think of the cuboid as essentially like a large, big cuneiform laterally, and that's how you can kind of remember that the cuboid is laterally, the navicular is posterior to the cuneiforms, and then you have your metatarsals and phalanges. The types of fractures, so when you're radiologically looking at films or you're reading the radiology report, it's really important to keep this in mind. So transverse is horizontal to the long axis, oblique is diagonal, spiral is generally associated with a rotational component, which is why there's such a long fracture and it's a bit jagged, and comminuted, there's a minimum of 2 pieces of bone. So, and then obviously closed versus open. So open is when there's tenting or breaking in the skin, and closed is when that's not the case. There's not exposed joint or bone. And intra-articular, extra-articular, this is more important in the foot, and we'll talk about that another time, I suppose, but intra-articular is essentially when the joint line, you can see it right here, extends into, the fracture line extends into the joint. So this is important when you're looking at things like long-term complications and sequela and why you would need more urgent procedures. So if it extends into the joint, that's more concerning for long-term arthritis and those types of sequela versus if it's more like an avulsion fragment. So that's extra-articular, so outside of the joint. So OTTOWA, we kind of talked about this very quickly during board review, but why do we check the lateral and medial mal for OTTOWA ankle? Any thoughts? So what are the important ankle fractures that we're concerned about in the ER? What would change our management? So anything that's unstable, exactly. And how do you determine what's unstable? Right. So the important ones that I'm going to talk about today are distal tibia, distal fibula, so the medial and lateral mal as isolated malleolar fractures, and then also bimals and trimals. But all of them are associated with either tenderness at the lateral mal or the medial mal or both. Or a minimum of 2, and so that's kind of how. So the high points, or the important fractures that you'd be concerned about in the ER, you have to have tenderness at these parts, and that's why these ankle rules came about. Similarly to the foot rules, where if you have tenderness at the base of the fifth, you're actually thinking Jones versus pseudo-Jones. So when you're doing ankle rules and foot rules, always think about what the pathology is trying to get you focused at. So as Neil just pointed out, the stability of the ankle is based on the ligaments. We're not going to look at the ligaments or memorize them. The most important thing to remember about the ankle is that the deltoid ligament is key, and that's what the entire stability of the ankle is based on. So when you're doing stress views, when you're evaluating the mortise, when you're looking at radiography, when you're measuring all these lines, and that's what radiology and ortho is doing, that's what they're looking at. They're trying to evaluate how stable the mortise is. So if you remember that stability is based on the deltoid ligament, and you remember these, this algorithmic approach, you'll be able to feel confident in like ankle fractures and approaching ankles in general. So first step, and we'll go through this in a stepwise approach, but first step is to evaluate the mortise, second step is to evaluate the fibula, and third step is to evaluate the stress view if you need one. And the whole goal of this algorithmic approach is to determine if the fracture is stable or unstable. So step 1 is evaluating the mortise. So this is what radiology does and ortho does. When there's an ankle fracture, you're looking for the tibiofibular overlap. And some sources say a minimum of 6, some say a minimum of 10 millimeters, but for example, this has 17 millimeters of overlap, and that's normal. And so you can measure this right here. So suppose you're at a community ED, post-graduating Jacobi, you're out by yourself, you're at a place like St. John's Riverside where they don't have radiology overnight. You have to be able to do these things on your own. This is what you're going to be doing. So first, you're going to be measuring this, the tibiofemoral overlap. Second, you're going to be looking at the medial clear space of the joint. So it has to be, if you're looking for widening of the clear spaces, essentially. So enough overlap and then widening of these two clear spaces. So if there's widening of the joint clear space greater than 4 millimeters, that's concerning for pathology. And instability of the deltoid ligament. And then additionally, you look at the mortise and AP view, you go a centimeter up, and you there's different parameters here, 5 versus 6 millimeters in the references, but if the tibiofemoral medial space is widened greater than 5 or 6 millimeters, that's kind of what you're looking at here in order to determine if the mortise is intact. So all of this is again pointing towards deltoid stability, and if the ligaments are intact. So that'll point you towards whether or not the joint is stable or unstable. And then you do this again, step 3, when you're looking at stress views, and we'll talk about that in a second. So as I said, this is kind of where the Ottawa ankle rules came about. The things that you're concerned about are you're going to have tenderness in the lateral or the medial mal or both, especially with bimals and trimals, etc. So what is, we just talked about this, and we're going to keep talking about this because this is one of the high points, but what is the management of ankle fractures based on? So cast versus surgical exploration, what is that all based on? How do you make that delineation? Stability of the ankle joint, right? So if they're stable, they could go home with a short cast immobilization versus whether or not they need more urgent reduction. The exception to this rule, does anybody know? So who are you not really concerned about in the ED? Would you not even worry that you would need a short light cast or surgical reduction?
Bed down patients?
Who?
Bed down?
Okay. No. So if you can't have surgical exploration, there's things that ortho can do if they are too high risk, but no, that's incorrect. Some avulsion fractures. So if you have small, less than 3 millimeter avulsion fractures that are non-displaced, both of those have to be true, and also you don't have any concern for medial joint instability. Those you can actually treat like ankle sprains. So that's the big exception to this entire rule. All right, so what is this classification system called? Shout it out. Weber, good. So what is this right here? What is this classification? A, right. And who said that, Tucker? No? How do you determine that that's an A? Where are you getting that from?
It's below.
Right. Good. So you're looking at the distal fibula fracture line, and you're comparing it to the syndesmosis. So this is called infrasyndesmotic, and that's where you get the classification. So this is all step 2. You're evaluating the fibula after you evaluate the mortise. So what is this called right here? What Weber classification is this? B. And why is it a B? Exactly. And so sometimes you'll see Weber, they'll still call them Weber Bs, but you'll see fracture lines that start here and come down here. But basically, but they can also be called Weber B2 as long as ideally the medial line of that distal fibula goes into the syndesmosis. And then what is this right here? What? C, right? And that's because it's suprasyndesmotic, right? Here's your syndesmosis and it's above it. And why does this matter? Why do we care about the Weber classification system? Management, right? And how does this differ? So how does A differ from C? Right, so A is the vast majority are stable, and these can undergo conservative management. C, on the other hand, need to do what? Surgical exploration, right? And B, how about those?
You need a mortise.
You need a mortise?
Like a stress view.
Exactly, you need stress views. And that would evaluate for the instability of the deltoid ligament. So if it's unstable, then you would need to go for surgical repair. If it's stable, then they can undergo conservative management. 50% of these can be managed conservatively, and 50% can be managed, have to be surgically explored.
Like that, when we have that much displacement of the space, like that's not.
Right, so most likely, yeah, exactly. Most likely these would need to be surgically explored. When you're, just from your initial evaluating the mortise, you would most likely know. Which, if you go through the algorithmic approach, you would know from step one. Okay, and so I'm just going to touch on two board fractures that you need to know. So this is a high Weber C. Basically, the idea of it, I'm just going to go quickly because we don't have time, but basically the idea of it is you're ripping all the way through the interosseous membrane and you end up with a proximal fibular fracture. And so that's a spiral fracture. And then this is the Bosworth fracture. Basically, it's a fracture dislocation. The posterior tibial tubercle, there's a break in it, and so the proximal fibula is actually stuck, and so it's a dislocation of that segment as well. So it's a fracture dislocation. These are actually exceedingly rare. Okay, so step 3. So we're doing stress views, and we established why. And does everyone need stress views, or who needs stress views? Does Weber A's need stress views? No. Do Weber C's need stress views? No, because you already know that Weber A's are going to undergo conservative management, Weber C's are going to undergo surgical exploration. Weber B's are the ones that need stress views. And why do what could we potentially be missing with the Weber B? Does anybody know off the top of your head? What are we most concerned about not missing with the Weber B? So it's a bimal equivalent, and we'll just talk about that in a second. Essentially with stress views, gravity has been shown to be just as useful as the actual operator doing the stress views, but essentially, generally they dorsiflex and externally rotate the leg, and that's what ortho's doing when they take the patient back for a stress view. So again, remember your 3 points. So the deltoid accounts for all the stability in the ankle, and then first you have to evaluate the ankle mortise by radiologically, then evaluate the fibula to determine your Weber classification, and then evaluate your stress views, going back to step 1, to doing all those key steps again to determine whether or not the ankle is stable. So this is what I was talking about earlier. There's some bimals that are very clear and straightforward. So the lateral medial mal is fractured and you're done. But there's a bimal equivalent, and so the bimal equivalent, I'll just go through this case and it'll be more clear to you. So this is the first case, and basically there's a fracture at the distal fibula, and then you undergo stress views and you see widening of this joint space. The idea of the bimal equivalent is that you don't know, without doing these stress views, if this is an isolated Weber B or if it's or if you're compromising the deltoid ligament. Does that make sense? So you don't know if that's just a stable Weber B or if that is an unstable fracture, so you can't necessarily be like, oh, I'm done sending this person home. If it's a bimal equivalent, that's an unstable fracture, and these people need to go for reduction. So this is an example of the bimal equivalent. These are all examples of positive stress views, so you can see widening of this medial space, you can see widening of this medial space, you can see widening of this medial space. So this is what you're looking for when you're doing stress views. And then we're done. I'm just going to finish up with trimal. So what is a trimal? What is the definition of a trimal?
Really, really, really fat.
Okay, so are there 3 malleoli? Where's this 3rd malleoli coming from? What is that?
Posterior tibia.
Exactly. So it's a misnomer, but they're referring to the posterior tibia. So you'll have a bimal with essentially the posterior tibia is also compromised, and so so a segment of that is off as well, and that's where you get the trimal from. Okay.